Minister of Health and Wellness, Dr. the Honorable Christopher Tufton, who is ably supported by our Permanent Secretary, Mr. Dunstan Bryan, our Chief Medical Officer, Dr. Jacqueline Bisesa McKenzie, our National Epidemiologist, Dr. Karen Webster Carr, and Dr. Melody Ennis, who joins us online. She is our Director of Family Health Services. Minister, over to you.
Thank you very much. Petre, good evening, ladies and gentlemen. Thanks again for joining us. I think we last had a conversation a few weeks ago, and we're happy to be back here today, despite the challenges that we will speak to that lie ahead, and that requires the absolute participation and involvement of the entire society. It's it's Thursday, July 22nd, and it's also the week that is designated as Nurses Week. And so before I get into COVID, I want to salute our frontline, or a category of our frontline heroes who have been working tirelessly on the COVID response, risking themselves, their families, to provide critical leadership on the ground. Nurses represent, of course, a significant part of the healthcare team. Currently, we have some 5,153 nurses and midwives who are engaged in the public health system. And as part of the Ministry of Health and Wellness, it is they who lead the charge around immunization coverage, around the fight against NCDs, or lifestyle-related diseases, dealing with infant mortality, mother and child care, and they are normally the ones in the field, at the primary healthcare level, going into communities, into homes, and providing the critical support that is so necessary to promote the best practices in health and wellness. So I do take this opportunity on behalf of the team here to salute our nurses on this Nurses Week, and to say to the association, the NAJ, we will continue to give us to our population. Today we face a number of challenges as it relates to COVID, and in the normal approach to addressing those challenges, we report and provide the information that we have based on the work in the field and the data that is collected, the trends that are determined on based on the analysis of that data, and provide the appropriate levels of advice to the populace, as we do to all other stakeholders. Our numbers, which will be presented on shortly, do suggest that we are moving in the wrong direction, and that is cause for concern. Our transmission rate is moving up, is increasing. Recent weeks have seen an uptick in the positivity rate. Up to yesterday, it was some 13.8%, with a 7-day average now at just under 10%, 9.8%. Now, from a benchmarking contextual level, you really want that rate to be 5% or less. The fact that it is moving up is a cause for concern. As it relates to the summary of the other areas, 259 or 33% of our 783 communities, as defined by Statin, have COVID-19 cases. So a third of our communities have the existing COVID cases based on our surveillance, and this links to dates of onset in the last 2 weeks. And hospitalization, unfortunately, is also suggesting or indicating an uptick. In the last 7 days, we have gone from 199 daily hospitalization to 251. Frankly speaking, being very direct, which we need to be, and transparent. This is not good for the country, and as it relates to COVID. This is not the direction that we want to head into. I know the Honorable Prime Minister spoke in the Parliament on Tuesday, and he's, of course, kept abreast of the daily numbers. He did indicate that there will be a review and an assessment based on the data that is provided. The subcommittee of cabinet will meet this weekend, Saturday, and I know we will engage in significant deliberations. And in keeping with our approach in the new week, I'm sure that we will inform the country as to where we are, what we think will happen going forward, and what decisions need to be taken to protect and to guide the population. So that's the sober sort of summary updates on what is happening. To give greater details, however, I'm going to hand over now to our national epidemiologist, Dr. Webster Carr, who will go into the numbers that would have led to the summary that I've just given. Dr. Webster Carr.
Thank you, Minister. So today's numbers show that we are now at 51,542 cases, of which 986 have been imported. We are at 1,167 deaths with a case fatality rate of 2.3%. The daily positivity is 13.8, as mentioned already by the Minister, with a 7-day average of 9.8%. When we review the age distribution, persons, as is usual or has been observed previously, persons 20 to 29, followed by persons 30 to 39, are the ones who have been most confirmed to have COVID-19. However, when we look at the distribution related to deaths, it's the older persons who are dying from COVID. If we look at persons over 90, 20% of persons who have been confirmed to have COVID-19 have died, for persons over 90. So when we look at sex, more females have been confirmed to have COVID-19 than males, but when we look at the deaths, more males have died with a case fatality rate significantly higher on the next slide, significantly higher than the females. The next slide will show the distribution by the different risk factors and comorbidities. 75% of persons are 60 years and older. 6 out of 10 persons have cardiovascular disease, and 4 out of 10 have diabetes. 1 out of 10 have neurological impairment, and 10% had chronic kidney disease. The persons have stayed in hospital between 0 and 85 days, so they have died the same day of admission or up to 85 days after, with an average age of 7 days. 10 persons were dead on arrival. When we look at the next slide with the parish distribution, and we will focus on the last 2 weeks, parishes with the highest absolute numbers include KSA, St. Catherine, and Westmoreland. But when we look at the number of cases per population, then Hanover and Westmoreland have the highest rate, and significantly so. So we ask the question, why is this happening? We observe that Westmoreland and Hanover are testing a little bit more than they were in the past. However, there seems to be a genuine increase in cases as the cases are not linked to other cases. So these are new cases coming up in the communities, and so there is an increase. On the ground, we are observing that persons are not following protocol. They're not wearing masks, not physically distant, being physically distant, and they're holding more events. They're holding more home events, especially funeral services are being held in the homes because they feel the churches are too strict. They are holding events in remote areas to avoid scrutiny. And so these are possible reasons. When we look at the deaths by parish, in 2020 and 2021, there has been increase in cases in 2021 over 2020. Next slide. When we look at the rates, the parishes with the highest rates includes St. Trelawney, St. James, and Westmoreland. Next slide. So we look at the geographical distribution, the spread in the country. About a third of the communities now have cases. But when we look by parish, next slide, the levels are higher in KSA, St. Catherine, and Hanover. Next slide. And when we look over time, we note that the cases were decreasing from the peak in week 11 of this year. However, it has plateaued and it's starting to increase currently. Next slide. So the number of cases started to decrease in March, and it plateaued earlier this month, but since the last few days have been increasing. The pink line represents the number of admissions for COVID-related admission. This has been increasing over time in the last few days. Next slide. When we look at the parish curves, we note that most of the parishes have that increase in cases, but the parishes of Westmoreland, Hanover, and Manchester is more pronounced. The next slide shows the weekly distribution of cases. In week 10, week ending the 13th of March, we had the greatest number of cases, and then we slowly decreased and to plateau in week 26, which ended on July 3rd. Since then, there has been an increase in cases and an increase in the positivity rate or the transmission levels. Next slide. When we look at bed capacity, similar features are seen, and the number of beds occupied decreased, plateaued, and is now increasing. When we look at the next slide, which shows the different levels of bed occupancy, it is now moved into the high pressure level, which happened over the last 2 days. Next slide, please. When we look at the positivity rate, which gives some representation of transmission, over the last few days, the positivity rate has increased. When we look at the next slide, it is now in the high level, and for this week up to yesterday, it has gone into the very high level. Next, yes, and so the trends that we observed in the last slide show that we peaked in week 11 at almost 39%, and since then we decreased to week 26, but we have been increasing since then. The last time we were at low transmission was last year in week 34. Next slide, please. When we look at the reproductive rate, we note that we are getting higher. Last week we were at 1.1 for confirmed cases. We are now 1.2. So this is very challenging, as this means that we are at a higher level of increase than we were last week. So this is concerning. This is the curve over time. And next slide, please. And this is based on the different interventions that have occurred. And since the relaxation, which started around June 3rd and the relaxation increased in around July 1, there has been, as you note on the curve, increase in the reproductive rate to where we are now at 1.2. And so the final slide is a summary of where we are for our main indicators. Our geographical spread level is medium. The bed occupancy is at high pressure. The positivity is at high transmission level. The reproductive rate is increasing. And when we see this is exponential increase in both cases and hospitalization, and our vaccination level, where it is now, is too low to have an effect on transmission or a significant effect on transmission. So thank you very much.
Thank you very much, Dr. Webster-Carr. So there you have it. This is the data. This is the science, and these are the facts. And there is no alternative to what was presented. This is based on the tremendous work on the ground, collecting the information, analyzing it, and indeed, we have a track record over the last 15 months or so to demonstrate that what the team present is based on those facts. So there is reason to be concerned. Indeed, there are reasons to be very concerned because the trends do suggest that we're heading in a direction, and that pace of increase can become a lot more aggressive if it continues on this trajectory. It also suggests that something is happening which would have started before you see the trend, and therefore it will get worse before it gets better, and certainly requires some sort of intervention. We are preparing, however, and I'm going to ask the CMO to give her assessment of our preparation. We did say some time ago that there was the distinct possibility of a third wave. I don't know if you recall, this would have been 2-3 months ago. We did indicate that our role in public health as part of the government of the day was to prepare for that, to look at our systems, to look at our infrastructure, our people, and to, where necessary, make adjustments so we can give that information to the country. Now, clearly, we'd prefer not to have that, and we want to work to avoid that. But the realities are what they are, and the data does not lie, and that's why it's so important. I want to just say, though, because I've been monitoring some of the news on social media since this morning, that we do not have any evidence of the Delta variant being here from the tests that have been done. But these tests are ongoing. We send samples out every week. And while there's no confirmatory test, I am prepared to say that we should assume that the variant is here. And I'm prepared to say that because the probability of it being here is probably greater than it not being here based on the border access and the travel restriction removal, including coming from countries where the Delta variant is now the dominant variant, the UK being one, or a main one, but also now the United States. And I'm not talking about any particular sector. It's not about tourism, because the truth is, as Jamaicans, we travel very frequently. The diaspora So once we have that kind of interaction, particularly in this case with a highly contagious variant of this virus, as outlined by the scientists, it is very likely, but from the tests that have been done, we have not yet confirmed. But results will continue to come in, and as soon as we confirm, we will make it known. The other quick point I want to raise is that in the last few weeks, we've heard of cases of clusters of persons who are vaccinated, who are tested and confirmed positive, primarily with not just an antigen test, which has varying degrees of accuracy, but a PCR test. And I just want to appeal to the public, the populace. Again, we say what we have said all along. The fact that you are vaccinated, and there are 300,000+ Jamaicans who have had at least one dose, the fact that you are one of that 300,000+ does not mean that you are totally protected from the virus. You can still get the virus. And indeed, the data coming out of some jurisdictions, I don't know if we have any confirmatory data here. I'll ask the CMO to comment on that. Is that vaccinated persons, some have contracted the virus and have died. The vaccine is not a 100% foolproof method of avoiding the virus in the first instance, not at all, and certainly avoiding severe illness. There is still that possibility. So it is so important, as we have said, that we maintain the protocols in the first instance, whether you're vaccinated or not. But secondly, you are, as a vaccinated person, are doing a disservice to your fellow Jamaicans, maybe friends, maybe family, who are not yet vaccinated. If you are, and you become complacent, let down your guard, and then you take the virus and you spread it to those who are not yet able to access a vaccine. And that we have spoken about, and that is becoming more and more a distinct possibility because of the notion that because I'm vaccinated, I can now move freely. The data is suggesting in other jurisdictions, as I believe it is here, that the pandemic is now shifting to becoming or being described as a pandemic of the unvaccinated. Because it is true that those who are ending up in the hospitals with the surges that are taking place right across the world tend to be overwhelmingly those who are unvaccinated. However, those who are contribute to that process by virtue of the fact that they can in fact pick the virus up, not be as ill, and can spread it to those who are not vaccinated. This requires an all-of-society approach, and I just want to emphasize that as I ask the CMO to look at our level of preparedness as we face or attempt to cauterize what clearly is a trend in the wrong direction. CMO?
Hi, good evening. Thank you, Minister. Good evening, everyone. I am just going to put up a few slides that are just going to just go over what's happening in the hospitals. And, okay. So this was a slide that Dr. Webster Carr had presented, and I just want to bring your attention to the pink line that looks at the number of admissions that we have been seeing over time. And we can definitely see that over the last couple of days, we are seeing a definite increase in the number of admissions. Next slide. In terms of our overall bed occupancy, in the yellow, we have the suspected cases, and in the gray, we have the confirmed cases. And we can see that overall, that at the end of the graph, there is a movement upwards. Next slide. Now, in terms of our bed capacity, the black line on the graph, right across, you have seen that we have been increasing our bed capacity. And right now, we have just over 700 beds that can be utilized for COVID. However, I just want to remind everyone that in terms of new beds that have been added over time, we have only added about 150 new beds. And so the other beds are really beds that have been taken out of general use, and so therefore impact on our hospital care. So therefore, we are challenged still in the hospital because in terms of elective cases, in terms of routine admissions, particularly to areas such as high dependency areas, we are limited in what we do because we do have to reserve beds for COVID cases. Now, in March, when our curve peaked, at that time we were severely challenged. We went above the black line, and as a matter of fact, some of those beds were added after the peak, and so you would have seen that we were significantly above the black line. And so therefore, what was happening was that it's not that we had patients on the floor, but certainly we had patients in other areas that were not designated for COVID. And we had patients waiting for long times in our emergency departments to get onto the wards. And also, this was at the time at which we ran into a little problem in terms of oxygen supply, and we had difficulty just for a few days in supplying oxygen to all our patients that needed it. So the danger of getting back to that level is quite clear in that we would be surpassing the number of beds that we have reserved, but we would be cutting significantly into our general hospital beds. And the challenges that we face where oxygen are concerned, then we would be facing a new challenge. So what we have seen over the last couple of days is not just an increase, but a sudden increase, because we have gone over the few days from 6% positivity rate to 8% positivity rate, then to 16%, and I think the last was 13% positivity rate. It's quite a big jump. And so therefore, the possibility of us getting into that danger zone may not be as slow as it happened between December and March. And especially if, as Minister says, that we do have the Delta variant, which is highly transmissible, then there is a possibility that that curve may rise very quickly, and so we could put ourselves in danger. So even more reasons why persons need to ensure that they adhere to their precautions, because as Dr. Webster-Carr has mentioned, the reproductive rate is climbing. However, if persons are positive and they are allowed to go about their normal business and unknown to them they're positive, then what it means is that they are spreading and the reproductive rate will continue to rise. What it is that we need to do is for those positive persons to stay at home as much as they can, to stay out of crowded situations, to stay out of situations where they can spread the disease, to ensure that they're wearing their precautions. And that is how we will ensure that they do not spread and to bring down the reproductive rate again. So it's very, very important at this time that people pay particular attention to what is happening in terms of the precautions, in terms of the crowded situations, in terms of any kind of environment that will be conducive to spread of infection. Next slide. This gives us an idea in terms of the moderately, severely, and critically ill persons. The moderately ill persons are in blue, and the severely ill are in red, and the critically ill persons are in gray. And we can see that in March, we had a substantial increase in all three categories. Well, let me refer first to September last year, August, September last year, which is the first peak, where we had significant increase in all of those categories. And then again in March, when we would have seen that increase. if you notice now, the blue line is going up again, and we're having more moderately ill persons that are coming into hospital. The red and the gray has not increased. We haven't seen the trend going up positively or consistently as yet. And what it is that we need to do to prevent that from happening is to ensure that our vulnerable population are vaccinated. Right now, we have a lot of persons who have received their first doses and still need to get their second doses, and especially those persons that are 60 years and over, that are the danger group, they need to ensure that they get vaccinated so that even if our hospitalizations go up, it would not pass moderately ill persons. And even if our numbers go up in terms of confirmed cases, then our overall hospitalizations should not, or we don't want it to, increase significantly. Next slide. In terms of ventilators, the use of ventilators over time, this is what has been happening. You would have seen that we would have peaked in March, and we have been up and down between 2 to 4 persons on a ventilator over time, sometimes no persons at all. But certainly over the last couple of days, we would have been seeing an increase in the use of the ventilators, and we do see that there are more persons here that are on ventilators lately. Next slide. Next slide. And in terms of our use of high-flow nasal oxygen, and this is what is critical in terms of our use of oxygen overall, because the use of high-flow nasal oxygen keeps patients off the ventilators. However, it does utilize a significant amount of oxygen, and the increased use of oxygen is what it is that puts us in danger of not having enough oxygen. And again, we can see a gradual increase at this time. Next slide. So therefore, what are we doing in terms of preparing, in terms of making sure that we are ready? And we go back to our pandemic plan, where every couple of weeks we have to look back and see what it is that we need to do new in these strategic areas in terms of, one, planning and coordination. And at this time, starting now, and we've had some meetings this week with our team members to certainly sensitize them, to increase awareness, to ask them to look again at their preparedness activities within hospitals and within health centers, because many persons over the last couple of weeks, with the numbers have gone down, would have started to do back routine activities to start to prepare patients for elective admissions. Now may not be the time to move so powerfully ahead with those, because we are expecting a surge, and how high we go is really what our challenge is, but we do expect that the numbers are going to go up. So in terms of planning and coordination, all our health facilities should be in that mode now, to be looking at what it is that they have prepared, looking at their supplies, and to make sure that they are ready. Well, main challenge in this area, of course, is our human resources, because we do know that we have challenges, especially where our nurses are concerned, and especially in activating those high dependency and critical care beds where you do require a high ratio of staff to patient. In terms of situation monitoring and assessment, we continue with our surveillance activities, and over the last couple of months, the country, I believe, can be confident in the information that we are putting out in terms of our numbers and the trends that we are able to show, and therefore to give some prediction of what is happening. Also, in terms of laboratory, we continue to utilize the resources that we have in both antigen testing and PCR testing. And of course, we are looking at our supply levels. Prevention and containment is the biggest area that we have to focus on, and this is vaccination. And we will later on speak about what is to come in terms of vaccination. But again, to create the demand for the vaccine is important at this stage, to ensure that all our vulnerable persons in particular are vaccinated, and of course our healthcare workers, where it is that we have hesitancy within our healthcare worker group, we need to address that to get that level, that category of persons within the population fully vaccinated. In terms of our health system response, we are looking at the capacity in terms of our field hospitals. We're looking at provision of oxygen and additional ventilators. And of course, in terms of communication, in terms of being responsive, in guiding the public and in preparing the public to prevent any kind of panic, to instill confidence and public participation in what it is that we're doing. So to move on to the specifics, in terms of some of these areas. In terms of the COVID-19 beds, we would have demonstrated that we had 716 beds that were reserved for COVID care. And for those beds, some of them would have reverted over time. At this time, we are probably looking maybe at, in May, we had about a 60% bed occupancy, and now we're looking at about a 30% bed occupancy of those COVID beds. And we are asking our facilities now to look again at the full utilization, preparing for full utilization of those beds. In terms of our field hospitals, we have 3 field hospital spaces that have been prepared, that are being utilized. The occupancy rates are low at this time, but of course with a surge we expect that they will go up. So at Spanish Town we have a 40-bed field hospital, at Falmouth and St. Joseph's. And additionally, with the support of the U.S. South Command, we will be installing another field hospital in Maypen to give us an additional 40 beds, capacity to go up to about 40 beds. And that field hospital is actually in country. It will be delivered hopefully by the end of this week, and then it takes another 5 to 7 days for setup. And that will give us some additional capacity in the southern side of the island. We also have a loan arrangement for 2 additional field hospitals that are in country through an arrangement with a private entity and the National Health Fund. And those 2 units are in country, and our instructions are that if the trend continues to go up, we will move immediately to utilize these. So in terms of the additional beds to be created, that is where we are looking at in terms of the immediate things that are being done and those that are shortly to be put in place. In terms of our general occupancy, generally speaking, we have just over 5,000 hospital beds in country. And in May, we were at about 60% general occupancy. Now, our general occupancy is going up a bit. As what happens at this time of the year, approaching the end of the year, the general occupancy tends to go up. And in some hospitals, we are now seeing that our general occupancy is going above that 85% alert level. So we have to be careful where this is concerned. The general bed occupancy is rising and is expected to rise coming on to the latter months of the year. However, in the face of a surge, what will happen is that we will employ emergency measures in terms of discharging of patients and the admissions of only patients that need to be in hospital for some emergency care, so that we will have beds that we can use. In terms of our ICU high dependency beds, we have brought in additional capacity in terms of ventilators over the last 15 months. We have 12 dedicated ICU beds and 19 dedicated HDU beds for COVID care. We do, however, have increased to 108 ventilators in country. And it's important to know that while it is that we do have that capacity, the utilization of these beds is really very highly dependent on staffing. Critical care is not just about having a ventilator or having the necessary pieces of equipment. The critical part of the care is the monitoring that needs to take place, and our nurses and critical care physicians are needed, and we are short in this area. So another plead to persons that vulnerable populations need to be protected Persons over 60, if you become infected, you have a high chance of getting a severe illness, and we want to keep you out of hospital because despite our efforts to increase our capacity, we still have limitations, and so we need to keep those numbers down. In terms of oxygen use, we would have seen significant usage of oxygen in August, September at our first peak last year. And then in March, April this year, we almost doubled the amount that we were using, which was significantly over our normal and routine use pre-COVID. Since then, we have in fact put in, procured through the suppliers, increased capacity in terms of the oxygen cylinders, with initially at first 200 more cylinders and then 800 more cylinders were made available, and there has been increased capacity put in place to produce oxygen at the plants. So we have actually, the suppliers have demonstrated to us that they have the capacity to produce and supply to us over the peak level of utilization that we had in March, April. Again, and a little bit over, but again, words of caution, because we really don't want to get to that level again, because consistency of supply is something that we will face even though we have increased significantly our capacity. In terms of contact tracing, I just want to reassure everybody that we continue to do our contact tracing, but our staff is really divided between the vaccination program and the contact tracing. And the difficulty sometimes in getting the cooperation of the public is evident when it is that we have persons that are not reporting their contacts, and then when the contacts are reported, they're not coming out for testing. So everybody needs to speak to somebody for them to be sensitized and aware that everybody has to play their part. Everybody has to be a surveillance officer. Everybody has to be a Ministry of Health officer if it is that we want to keep our numbers down and keep our country safe. And I think that's, in terms of the human resources capacity, this is where we have our challenges, as we would have mentioned. And one of the challenges that we do face is the vaccination take-up in our healthcare workers. And at this time, I want to just encourage all our healthcare workers who have not been vaccinated that they need to ensure that they are vaccinated, because we have to keep the health system up in order for us to be able to respond appropriately. In terms of our supplies of personal protective equipment, we are receiving steady supplies, and now what we have done, as we did in December, because with the efforts that we made in December to get in buffer stocks into the regional health authorities, you would have recognized that March, April, when we had that severe increase in the number of cases, we did not have problems in terms of personal protective equipment. And again, we are doing this. We are contacting again our donor sources, and we have supplies that are coming in that we are directing straight to the regions in order to build their buffer stock so that they're able to respond. In terms of testing capacity, we have also reached out to our suppliers. We have adequate supplies in stock at this time for both PCR testing and antigen testing, and PCR testing using both the COBAS and the open method of testing. So we have enough stocks in place, and we have reached out to our suppliers. Up to today, we have been speaking with them, and we have on order to come in additional stocks to ensure that we are prepared in case we are responding to a surge. That's my last slide. Thank you, Minister.
Thank you very much, CMO. So there you have it, an update on the preparedness of our hospital infrastructure, including personnel. Remember now, this is to some extent to reassure the public that we are alert and always prepared to respond. It is not a prescription, recommendation, and encouragement for complacency or for persons to feel that because they can or may be able to turn to a doctor, a nurse, or a hospital, an institution, then all is well, we can go about doing all things without the personal responsibility of mask wearing, sanitizing, and social distancing. This is a worst case scenario to want to report to a medical facility. The best case scenario, clearly, is that we avoid putting ourselves at risk. And I just want to repeat that because that is so important so to avoid further contamination of the virus. To reinforce some of what was said earlier by Dr. Bisesa Mackenzie, we invited two of our SMOs, senior medical officers. This is the medical officer on staff at a hospital that drives the medical team and the medical program and the medical response. And they are referred to as SMOs as opposed to CMO, who is the chief of all of those SMOs. We have with us Dr. Baker from the National Chest Hospital. Is she on? Stephen? Okay. And we're just going to give her a minute or two just to ask what's happening and how does a hospital prepare for this kind of eventuality. Dr. Baker?
Good evening, Minister. Good evening, CMO and other members of the head table, and thank you for inviting me to join.
Okay, so just thank you for joining. Just quickly, what's the current status at the National Chest Hospital, and how do you manage both in your present challenge, but also in anticipation of maybe a greater set of challenges?
So we have used the period after the second wave to really look at our facilities, both infrastructure and human resources, because as was said before, even though we prayed and hoped that we would not go along that path, we were told and even looking on to expect that we may jolly well be facing a third wave. So we used the reduction in the number of cases after the second wave to sort of refurbish one of our wards, making it a bit more hospitable for potential patients that may require admissions. Currently, we have 42 beds available for the management of patients who require admission, with the capacity to increase that number to 63 if required. We have used the opportunity to ensure that the majority of our beds have what we call piped oxygen, and we ramped up our oxygen capacity as well. So when we have piped oxygen, oxygen delivery is more stable versus using cylinders. This is not to say that we won't need cylinders, but hopefully we won't be as dependent on it as before. We, as CMO mentioned, PPEs were never an issue during the last wave. We're using the time to check our accounts and make sure again that we have sufficient in stock, but this was never an issue for us. And we're using this period as well to look at our monitoring equipment. We have already spoken to our administrator and have our biotechnology team in. So these monitors were used quite heavily during the last wave, so we need to make sure that they are ready for the third wave. In terms of human resources, we have sufficient staff at the moment to manage the number of patients that we have. And if it is that we do see the wave, what we have in place is a repository of persons from whom we can call, to come in if needed to supplement the staff. And this would include doctors, nurses. We lost some nurses in terms of nurses who resigned or went away to study. But as occurred with the last wave, nurses who had gone off to study returned to the hospital when the demand was needed, as well as we are preparing to recruit other nurses. So yes, this is not the direction that we would like to be going in, but it is a reality. We pray that we don't have a severe wave. We have noticed the numbers going up during the latter part of last week and as well as this week. And therefore, we are preparing by putting things in place and having resensitization for staff members as is required.
Thank you very much, Dr. Baker. Thank you for your work. Thank you and your team. And just a little synopsis there for the benefit of the listening public, that the health system is always willing to do what is necessary despite limitations. Not an encouragement to get sick, but hopefully a reassurance that we are always prepared for any eventuality. The other SMO we have online is Dr. Harvey, who hails from the West, Cornwall Regional Hospital, a champion in that side of the country, working despite challenges there. Dr. Harvey, are you on? Dr. Harvey? No?
Get on.
Okay.
Good evening. I was just being unmuted. Sorry about that.
That's
Thank
fine.
you very much. Good evening, Ms. Honorable Minister and members of the panel, and to the press in general and the wider Jamaica. We have been preparing here in Montego Bay since March, since early January 2020. And as Dr. Baker said, we have anticipated that there may be a third wave. As you had just alluded to the fact that we have challenges at Cornwall in particular, we had repurposed our temporary areas. Now, what happened was that since the last breakout in February, March, we have had the addition of, as Dr. Baker had in National Chest, additional piped areas. We have received some donations of high flow oxygen nasal cannulae, as well as the addition of an 8 or a 9-bedded area, which is more purpose-built than using the temporary area, which we had repurposed early last year. We have, as you have alluded to, not had any challenges with PPEs. Our challenge would have been human resources, but we were fortunate enough to get assistance from our colleagues in Cuba when the pandemic started, and continue to receive that assistance. The manner in which we have managed the pandemic at Cornwall now more involves the internal medicine team, who are taking on a greater role, as on their wards we have also repurposed rooms. As was stated earlier, we were looking forward to going back to doing some elective work. We have started, but we are aware that that may have to go on hold. Cornwall, as the public may or may not know, received a high dependency unit, which has the capability of ventilating 4 patients. However, our limitation would be the need for critical care staff. And although we are limited in numbers, we do use that facility to do non-COVID patients. So overall, the picture is similar to that which Dr. Baker has mentioned. We continue to have weekly briefs at the administrative level. And when the clinical team, as the pandemic evolves, we do have our infection control meetings, which are held regularly, but will be held more regularly as we go forward. In addition to the clinical care which one gets at Cornwall Regional Hospital, we also have great partnership with our colleagues in primary care who have helped to offset some of the load, and that includes not only contact tracing, but doing some of the follow-up. Thank you, sir.
Thank you very much, Dr. Harvey. I appreciate that. It clearly appears that, and as we have always said, that personnel is perhaps one of the biggest challenges. We have had a team in the field responding to the COVID-19 threat, at the same time trying to cope with all the other healthcare demands that is expected of us. And because of the numbers, not a lot of breaks in between. And it really has made it very challenging. There's significant fatigue in the system, on the system. And, we are, should I say, in some instances, literally operating on steam. I want to really take the opportunity to commend those, like the two SMOs who spoke earlier, but the thousands of others in the field who continue to give their efforts. And I want us to encourage, as a country, them as they continue to make the sacrifices, to work on the front line, to provide care, and do so under challenging circumstances. Sometimes we make mistakes. I mean, that's human, and particularly in a high-stress environment. But I think, for the most part, as a country, we can be proud of our healthcare team. I'm certainly proud of them as their Minister of Health and Wellness, and I believe we should recognize them for their efforts. Up to July 2021, meaning up to yesterday, we inoculated, at least with our first dose, some 300,833 persons. So over 300,000 persons have been vaccinated. 178,700 of whom received their first dose, and 122,000 have received their second dose. I know that persons have been critical, and this is our democracy, so persons are well entitled to give their views around the extent of vaccination in the country. And I've seen every reason for why we are not vaccinating more persons. It is true that unvaccinated persons are going to be a lot more vulnerable. And in the context of a surge, they need to be particularly careful. As I said earlier, vaccinated persons who could transmit to those who are unvaccinated. I want to say that, while I accept, and we should accept, that we would have loved to be far more advanced in our vaccination efforts, the truth is, it is and has not been for a lack of effort on the part of those who have been responsible for sourcing, communicating, negotiating, in some instances, even asking for a sort of preferential, if you will, treatment to access, whether for pay or as a gift, vaccines. We have benefited from the generosity of those countries that have an advantage by virtue of where vaccines are manufactured and who controls those brands. And we are now, as I said, up to 300,000. I've seen comparisons that have attracted criticisms around countries in the Americas and where Jamaica is. And it is true that based on our numbers, we, on a per capita basis, we are at the tail end of those who are vaccinated. But it is not for a lack of trying. And I'm not speaking here only on behalf of the public health team or myself as minister, even though I accept any criticism that is levied. I mean, I understand that is the nature of the job. But this effort has been an effort far beyond us. I mean, the Ministry of Health, a lot of it involves diplomacy and the Ministry of Foreign Affairs. I know the minister has done significant work reaching out to governments, to our colleagues, to negotiate, to get access. The Prime Minister and others, even in the private sector, Mr. Mitchell at the NHF and so on. So it has been a real challenge based on limited quantities and increasing demand. And it has really tested us in terms of achieving the objectives that we would like. Having said that, some of those comparisons too don't offer a lot of value, frankly speaking, to the discourse and to the response to the threat that we face. I mean, for starters, we're compared with countries that have populations that are far less than ours. Some of them are territories of more developed countries, so they benefit from those relationships. And, a country with a population of 20,000 or 30,000, it's not difficult to access half of the numbers of vaccines. a 3 million population has a little more difficulty, even though I do agree that the per capita comparison could be viewed as a comparison of the risk mitigation measure and the response. But there are other circumstances. This is not an excuse. We continue to work diligently and will continue to work consistently to get vaccines. But I want the country to recognize, too, that what has driven the approach to vaccines has been to ensure that when we introduce a vaccine to the population, in keeping with our immunization policy, which we have a very strong history in, it is, from our perspective, safe and offers the protection to the population and at very minimal, if any, risk to that very population. And so sometimes we are criticized, why didn't we accept this vaccine or that vaccine? Clearly, government can change policy, but the government is always mindful of the need to keep in place a policy that would introduce or provide vaccines that are safe. So the approval process, the clinical trials, these are all things that we look at, and we look at them in collaboration with our multilateral partners, the WHO, PAHO, and others, and that has driven the approach to the vaccines that we reach out and attempt to get. I just want to say that we are very hopeful that vaccines or additional supplies will arrive and arrive soon. You would have seen in the media space discussions. For example, you saw where the British High Commissioner spoke very committedly and decisively about vaccines coming from the UK. And soon, those conversations are continuing, and we anticipate in the week to come that we will be able to give some more specifics around dates and quantities and so on. And so we do expect in the new week those arrangements to be concretized. I don't want to give specifics, but he spoke to it, so I'm agreeing that those discussions are taking place and we should hear something, and those quantities will be fairly substantial. The African platform providing the Johnson & Johnson, which we have paid on, so this is a purchase, we continue to have those conversations, and we believe that in the new week we will have some specifics, again, including dates, which we will provide to the populace. I don't want to say anything until I have those dates. Indeed, I am most comfortable when the vaccine is loaded on the plane and it is in flight, because we've been down that road and we have seen so much uncertainties that I prefer that. But I'm encouraged that that is certainly in train. And then there are other areas of discussion, including COVAX. Now, just to remind ourselves that we did say months ago that August, late July, August, would have been when we see the sort of opening up of vaccine supplies. And we're still on that track. We're still on that track, our trajectory. June was a challenging month, and we did say it would have been a challenging month. So for those who may not recall and are critical, I ask them to be patient and just recall that we did indicate that we would have had to go through this period. For those who are waiting, I would like to say the wait will not be much longer, and the policy that is likely to be pronounced on as it relates to vaccines once those shipments come in will be to open up the vaccination program to all who qualify. So there'll be no restrictions on age cohorts. So anyone, in this instance over 18, who can access. The policy will also support an approach, a plan, which we're working on, that will see us going into communities, greater outreach, using mobile units. In other words, taking the vaccines to the communities as opposed to just doing the blitz in the traditional form of having locations where we bring people to those locations. The health centers are going to play a more active and continuous role so persons can visit. And we do intend to engage our stakeholder partners, including the private sector, to be a part of the process. All of that is being worked on in anticipation of larger quantities of vaccines and the opening up to all of those populations that qualify. We are targeting or attempting to inoculate, assuming the arrivals of those quantities, between 800,000 and 900,000 persons by the end of September. The vaccines that are being planned for would allow for that. It is going to be a function of the logistics and the management on the ground of that process and the willingness of Jamaicans to come out and to benefit or take the vaccines. And so we want to use this opportunity to encourage the population to be patient. The wait is not going to be much longer, and to participate in the process when that process is announced, and for other stakeholders to come on board and let us work as part of the effective response to the pandemic challenge. All right, so I think I have exhausted the advisories on vaccines. I've abandoned the script because I feel so strongly about this issue of vaccines. And I just want to close and open the floor for questioning by saying that please remember the protocols that you must and should observe, irrespective of whether you're vaccinated or not. For the vaccinated, please remember you can still carry the virus, pick up the virus, and be affected by the virus. And for those who are not, please hold strain, protect yourself. The vaccines are on their way, and we will give better particulars in the new week. And from there, a program to inoculate or to vaccinate. Thanks to those who presented, the CMO and our chief epidemiologist. And the floor is now open to you, Stephen, for questions. Thank you. Or, sorry, Petre.
We had a bit of a glitch with our Zoom earlier, and so we just want to apologize to our media partners. That said, it is now time for the questions, and the first question this evening goes to Janet Silvera of The Gleaner.
Okay, thank you very much, Peter. I have some questions. The first question is to the medical team. I would like to find out if the team did not imagine this happening when the country was opening up so widely. And if you did, what type of recommendations did you give to the government? I'm not sure if the minister was saying that private doctors will also be part of the vaccine process, administering the vaccine. I'd like to find out if that will be the case. And the third question is, could what is happening now affect the major dream weekend that will be staged in Negril? And final question, the Chinese have been asking for their Sinopharm, owing to the fact it is obvious that they would prefer to take their own vaccine. Has the government considered this as yet? Thank you.
The first one is, all right, I'm not going to be unfair to the medical team, Janet, as I'm sure you don't want me to be. The technocrats in the ministry do not make policy decisions. Those are made by the Cabinet of Jamaica, of which I'm a part. We, meaning the technocrats, give advice, technical advice, and they do so diligently each week. having collected the data, as is the case with our conversations when we present. It's really an issue of managing risks, having received that advice. So I speak now as a member of the executive arm. Having received that advice, the conversations that follow, which are private, and so I don't think we should, I'm not going to comment on what transpires at cabinet and what advice you gave and so on, because those are protected by law. But nevertheless, the general principle is to consider all the advice that is given. And remember, no, it's not just clinical advice. There is advice representing all stakeholders, captured under the concept of balancing lives and livelihood. And out of that, the policymakers make the decision. And that is the cabinet, chaired by the Honorable Prime Minister. I clearly am a part of that, and the concept of collective responsibility applies. And what I said, post those announcements and decisions around relaxation, as did the Prime Minister, is that, one, there are risks associated with the decisions. Those risks are determined by how we all act, whether from an enforcement perspective or from an observation of the protocol perspective. Those risks come with consequences, but are determined by other concerns and considerations, some economic, but some also social. The mental health of the population, for example, the restrictions and the impact. And finally, depending on how those risks play out, there is always the fallback to retreat back to some of the original positions to correct a risk that becomes wayward and moves in a direction that is not desirable, as it is now suggesting. And I think we've been very clear on that. So it's really up now to the cabinet to have a conversation around where we are and where we need to go, and whether some adjustments are made. The Prime Minister telecasted his position in the Parliament on Wednesday, I think it was. So let's see what happens for next week. On the issue of private doctors, yes, the intention from a inoculation or mass vaccination perspective, if we hope to achieve that target, and that target, by the way, would give us approximately 51% of our targeted population, and about 33% or so of our overall population, if we were able to get to the 800,000 to 900,000 with the addition, with the numbers that already are there. So it's an ambitious target, but we believe it can be done, given that we did 80,000 in a 4-day period, once the country comes on board and all hands are on deck. And those hands on deck would have to include private physicians. We would have to determine on the logistics of that, the protection of the vaccines, so the locations would have to be selected carefully. Can't be everyone anywhere they are or every private practice. But we would certainly want to engage that population. And some discussions have started along those lines as part of the overall private sector. So yes. Could what is happening now affect Dream Weekend? Again, I can't comment with any certainty around either Dream Weekend or how it may affect Dream Weekend. The policy of the government, has allowed certain activities to take place, so it is a legitimate, organized event. But the policy of the government also has accepted that where risks are too great, they reserve the right to make adjustments. And that is a collective decision, which I will subscribe to, and therefore not be definitive on any position beyond the fact that we continue to assess the risks and will allow decisions to flow from that. In terms of the Sinopharm question, Sinopharm is one of several companies and countries that are offering vaccines to the marketplace. As I had said earlier, vaccines have to be approved. In this instance, that entity now has WHO approval, and there's a conversation that is taking place which would allow decisions around the, accessing that particular brand, as is the case with the others that I have commented on. So it really now becomes a function of what is available, how much we can use at a particular point in time, because we don't want to take it and waste it, because there has to be a relationship between what you access and what you can serve on the population based on the personnel that you have, the infrastructure that you have to do it. And so quantities have to be now looked at in terms of our capacity to deliver. But Sinopharm is certainly one of the candidates that is under active consideration and discussion. But they are behind others that have had concrete decisions taken, and we await the arrival of those quantities. Thank you.
Thank you, Minister. Our next question goes to Christopher Thomas of the Gleaner.
Yes, good evening, Minister and your team. Are you all hearing me?
We are. Please
Yes, go ahead.
Okay. All right. I have 3 questions here. First question, Dr. Bisesa Mackenzie earlier briefly made mention as it relates to the possibility of discharging of patients from the hospitals. I want to ask specifically on the matter of social patients, as we call them, those patients that are just at hospitals taking up bed spaces and making use of the facilities, even though they don't have to be there. And this is a special problem right now with the need for bed spaces in this COVID period. What is being done at this time to address that, to make sure that they are actually, when you say that they can be discharged, that they actually are discharged? That's the first question. My next question is, in light of the expected wave of COVID that is coming up, how is this likely to impact any guidelines, any COVID guidelines that may be needed for the upcoming school year to come in September? And are those discussions being held or going to be held between the Health Ministry and the Ministry of Education? And my third and final question has to do with what was published today, where you, Minister, you basically floated out the idea of possible mandatory vaccination. But if such a thing should happen, would that not be, as some persons might suppose it to be, an infringement of their right to choose whether or not they actually want to take it, especially those who may be concerned about any what they may see as health risks associated with vaccination in general and COVID vaccination in particular? That's it.
All right, I'm going to ask the permanent secretary to speak firstly to the social cases, because I know he has been dealing with it in some ways.
Thank you very much, Minister. So social cases continue to be an issue that we grapple with in the health system. In the beginning of January, when we saw that we needed to to free up more bed space, we had collaborated with the Ministry of Local Government and Rural Development to ensure that some of our social cases that were in hospital for, in some cases, up to 7 years, that we could find space for them in the infirmary and to declare some of them what do you call it now? Blank. Poor. There's a particular legal term that is missing me now. So we had moved of the 357 social cases that we had in hospital across the island in January. We had moved some 200 cases out of hospital. Since that scenario, we have approximately another 100 or odd that have come onto our role as social cases in hospital. Social cases are defined as any patient that is discharged from hospital but have not been received by their family or have been collected and returned to homes. And so we continue to grapple with this issue of social cases in hospital, and we continue to collaborate with the Ministry of Local Government and Rural Development. However, they too have their issues where they are no longer have infirmary beds to accommodate social cases in hospital, and we are unable to locate and we are unable to identify the families. Now, the ministry will be engaging in a legal process around social cases and the fact that we have to pursue the families through the legal channels and to ensure that they are required to take responsibility, especially for the elderly, that we find most of our cases being persons who are infirmed or bedridden and elderly, and they need to have the legal process followed. Thank you.
Let me just quickly comment on that with a little more directness, if you will, because it is something that I've spoken to publicly a few years back, and had committed to doing something about it by engaging the legal process to test in the courts the actions of some who have the responsibility for their elders, their parents, their others, persons who depend on them, having provided for them in their earlier years. And they literally, and I must tell you, I was shocked when I discovered this, only having become Minister of Health, where persons literally take their loved ones to the hospital, drop them off, and leave them, no questions asked, and expect the hospitals to care for these persons with no end in sight. So these persons end up literally living in the hospitals. I have asked for reports and seen in some institutions where persons have been there for a year, 2 years. I've seen someone at a hospital for as long as 5 or 6 years in a bed, in an area where they have all the amenities of a private, small space, which is literally set up like it's a permanent resident. Now, I am very sad for those individuals, and we must show empathy because many are in a position not to do much beyond what their current state is for one reason or another, whether it is because of a health-related matter, they're a victim of stroke or some other incapacities affecting them. What I am very concerned about is that persons who are or should be responsible for them literally totally abandon them. And in some instances, we have cases where these persons occupy their homes. Indeed, we have seen where on the death of 1 or 2 of these individuals, persons turn up asking for the death certificate in order to inherit the property that they leave behind, while not providing any support for these individuals. If you go to Bellevue Hospital, almost 500 patients there of the 800 patients that are there are literally social cases. The challenge I have with the question as to how we deal with this on a base on in the context of having more beds for COVID is that no sooner you take out these persons, the beds become filled again by others coming in. And therefore, the solution it is not to just move persons to an infirmary. It has to be to adjust policy to directly hold accountable those who should be the caregivers. And I think we would like to see some policy shift, maybe supported by some legal opinion or judgment that makes it very clear that you have a responsibility to those who whether brought you into the world because it's a parent or otherwise, and there's some legal status that accompanies that, which requires you to look after these individuals or at least provide some sort of care. The hospital is not a place for social cases, not an infirmary. It's a place for sick people who are intended to stay for a while and then exit, hopefully back to their homes, but worst case scenario, to a final resting place. And this is why the PS has spoken about the need for some sort of legal position and possibly some policy shift over time. It's an ongoing challenge, and it's one that we have to deal with. And it does take up our bed capacity. At one stage, I think 10% of our beds were taken up, or close to that, between 8 and 10% by social cases, and others were waiting to be admitted with problems that really requires a hospital bed. So it's something the country needs to contend with, and we as policymakers need to address. The issue of school and the guidelines around school, I don't know if the clinicians want to speak on that. I mean, that's going to be an issue of what happens over the next month. That's going to be based on the advice at that time. And then, of course, the decision by us as policymakers, the cabinet. My own view is that we really need to see school reopened. Our children are suffering. They are traumatized by being at home for over a year. And we're seeing manifestations of that in terms of their mental state. And it's just bad all around. It's therefore not a desirable position at all. And I know the government is keen on seeing school reopening in September. And we're working towards that. I know the minister has spoken about it. The cabinet has deliberated on it. But we'll have to await to see how we manage over the next month. The issue of the mandatory vaccine coverage, or that is attributed to my comments. Just for context, it was said at the Parliamentary Committee on COVID Matters, and what I said is that we have to look at hesitancy at some point in our vaccine response. We believe that we will see a certain number of Jamaicans still being eager to take up vaccines once those vaccines are available, maybe up to 1 million or so. So if we carry through successfully the plan to the end of September, we will hopefully see take up to that level. We do believe that over time you will have hesitancy. You will have persons who don't want to take the vaccine. And to the extent that that hesitancy is hard, and the COVID virus remains a threat to the wider population, not just to those individuals, but to the greater good of the society, then we will have to look at exploring other means, other ways of encouraging take-up. Now, that has been interpreted as my saying mandatory. What I believe I said was that in other jurisdictions, and we continue to look at those jurisdictions, we have seen where policies have shifted towards encouraging and in some cases legislating or policy around take-up. So access, for example, to buildings or to particular spaces. Indeed, we have seen where governments have said government workers, for them to work in the public space, must be vaccinated. A few countries have done that. We've seen employers taking positions. Now, I know there are different views on this, but the reality is that we operate now in this society where to go to public schools, you have to take a number of vaccines. The MMR vaccine and others, the clinicians can comment on it. Unless you take those vaccines, you're not allowed in the public school system. So I'm not suggesting an alien concept, and I'm not suggesting that this may be the way we go as it relates to COVID. What I am saying is that there is a point at which, if take-up becomes an issue, we have to explore additional policy measures. And there are extreme positions that some countries are taking. There may be other more moderate positions, but it's going to be a function, I think, of what happens and how much the threat is a threat on all of us as the citizens of the country. Thank you.
Thank you, PS. Thank you, Minister. Our next question goes to Jamaica Social.
Hello, good evening, folks. Can you hear me?
We can. Please go ahead.
Yes, you can. Okay. Minister, the nation recently noticed that doctors and medical personnel being disgruntled about a number of things, including the fact that they did not support the or extensive opening up of the nation on the first of the month. Now they are looking literally at another wave that they'll have to deal with. The same personnel who were clearly disgruntled and annoyed by the fact that they feel decisions are being made and not really taking into consideration the stresses that they're already under, and that will, eventually would impact them. Your thoughts on how you see the Ministry of Health's relationship with doctors going forward into a third wave, which would be, as using a phrase from the chief medical officer a couple weeks or months ago, that we just can't afford to have it. That's one question. The other question goes to the chief epidemiologist, Dr. Karen Webster-Carr. It was declared, I believe, by the Prime Minister or the Minister of Health in around March, somewhere there, that almost 40% of the population have already had COVID-19 or come in contact with the virus. Your thoughts on at what point would we, with so many people being infected already, wouldn't we be closer now, going through the last wave, above 50% or more? And what impact will that have on the whole concept of herd immunity and really the how bad a third wave would be? That's it. Thanks.
All right, so I'll answer the first one. My recollection is that the doctors that were expressing some disappointment was as it relates to payments and contracts and so on. I'm not sure. I don't recall that kind of description around doctors related to measures related to the COVID or the easing of restrictions. I think we were able to solve at least most of the concerns, and that's normal in the regular course of things. We don't always agree, and when we don't, we resolve them. And I think we did so in a responsible way and swiftly. So I commend the team for that, and I appreciate the doctors for coming to the table and agreeing to a resolution, even though they didn't get everything that they asked for. But that raises a bigger point, the principle being that even in cases where you may not agree with all that is being done or said, it doesn't provide sufficient justification to abandon your post or indeed your mandate, or indeed your oath, which is to save lives and to provide protection. And I think that to the populace, of course, health protection. And I think that the doctors, even with the stresses that they face, doctors, nurses, the healthcare workers, they are committed. They're committed. That's what they are trained for, even in adverse circumstances. So I'm not anticipating that anyone will abandon their post because they may not have agreed with a policy position. That's not the society we live in, and that's not the nature of our Jamaican spirit and Jamaican people. So we will give all the support that is necessary, meaning the government, the ministry. We will correct any ills that are perceived, and we will continue to expect a working relationship that responds to our core mandate, in this instance to respond to the pandemic, whether there is a wave or whether the seas are calm.
Okay, thank you for that question. So we did some modeling at the end, up to date up to the end of May. We got about a 3.7% immunity based on the cases that we have had. So it's about a 3.7. So, and I don't think it would have changed much. So it would be under 4% immunity to COVID-19. So that would not affect our herd immunity very much. Thank you.
Okay, thank you, Minister. Thank you, Dr. Webster Carr. Our final question this evening goes to Emma Lewis. Emma, you have the floor. Emma, are you there?
Yes, yeah. Oh,
Okay,
sorry.
yes.
Sorry. I'll start again. Can you hear me now?
Go ahead, Emma.
Yes, I've unmuted. Can you hear me?
Yes, we can. Go ahead. Go ahead.
Oh, okay. Okay, thanks. Okay, sorry about that. Yes, I just wanted to check the hospitalization numbers again. The minister mentioned some rather high numbers. Maybe I got them, I noted them down wrong. But how much from what number to what number have hospitalizations increased in the past week? I had 122 were the numbers from yesterday, but I think I heard you say a much greater number, but perhaps I got it wrong. The other part of my question is, you mentioned the commitment of healthcare workers and so on, but why aren't they all getting vaccinated? I don't, in particular the nurses. Do you have any comment on that? If they're not getting vaccinated, why not? Thank you.
Dr. Webster, you want to respond, or Dr. or CMO?
Right. Thank you, Emma, for the question. You're looking at two different reporting types, because in our updates that is printed in the media, we report the number of confirmed cases. In our presentations, though, we talk about bed occupancy, and bed occupancy includes those cases that are suspected cases as well as the confirmed cases. So we would have seen that our overall bed occupancy for COVID-related cases would have increased to just above 250, which we haven't been there for a while. I think we probably started out a few days, maybe 7 days ago, at about 200, and we have climbed up to about 250. I might not be too exact on the numbers, but that is confirmed and suspected cases that speaks to bed occupancy, while what is reported daily are confirmed cases that are hospitalized, where you would see that that has varied between, it was under 100 consistently for a while, and now we're seeing it going above 100 to about 122.
Thank you, Minister Kantisi. But if you could allow us, Minister, Debian Wright, please go ahead.
Good evening. I'm just asking one quick question. Do you now have any definite information on whether people are missing their second dose of the vaccine?
I understand. Dr. Ennis is online, or head of family medicine who is responsible for the vaccine program. Is she on? Dr. Ennis, you heard that question? You want to respond, please?
Yes, thank you. Good evening and thanks for the question. So we don't have definite numbers, but what we do know
Dr. Ennis, you may have muted yourself.
There seems to be there's a technical issue. We don't have the numbers, but what I do know is that there are some persons who have exceeded the 3 months, and the experts have said that you can go up to 4. I think I saw Professor Figueroa recently discussing that issue. So that's one issue. We are still administering second doses despite the slowing down of the process. So persons can still contact us. One of the challenges that we face, I am being told, is that there are a percentage of first doses who have indicated that they don't intend to take the second dose. So it's not just an issue of availability of vaccines, because we still are providing second doses, despite the limited quantities, which is why we're not giving to anybody else. But there is a percentage of the population, for one reason or another, who are not inclined to take the second dose. I want to use the opportunity to encourage them that it is very important in terms of their full protection, and there is an approach to try to reach out to those persons. Is she back on? Dr. Ennis, you want to
Yes.
just quickly...
Yes, Minister. So it's a very small percentage of persons that have actually indicated that they are, not interested in taking the second dose. They have really, when spoken to by the health team, pretty much say that they want to wait a little bit. So because of that, we now have persons that are in week 14 going into week 15 of not being inoculated. Be reminded that the recommendation remains that as soon after you've passed the 12th week, then you should be vaccinated. So we continue to engage those persons who have certainly indicated to us that they are unwilling, and we are tracking all the persons who are in excess of the 12 week, and we are making direct contact with them through the health departments and inviting them to come in for their second shot.
Thank you, Dr. Ennis. That is all the time we have for questions this evening. Minister, back over to you.
Okay, thank you very much, Petre. Thank you to you and your team and to the technical team who are here and to my colleagues on either side for their role today. We've had a fairly extended COVID conversation this evening because there's a lot to talk about. And I want to just thank those who participated, those who will help us to get the word out to the population. The news is not as sanguine as we would like it to be, not as encouraging. It's concerning because of the increase in numbers in a number of the key categories: positivity, reproductive hospitalization, trending up. And the Honorable Prime Minister did say that we will have a discussion around that next week, having had a cabinet COVID subcommittee meeting on Saturday, which we will, I'll certainly be there and the team to provide advice. So next week the country will be updated further on that. But in the meantime, we encourage persons to respect and to follow the protocols. Those who are vaccinated, you can still get the virus and can transmit it to those who are not, which makes them more vulnerable than you. And you can also be affected negatively, illness and even death in some cases, even though you have had your dose. So it's so important that all of us play our role in terms of doing what is necessary. On the vaccine front, we continue to be encouraged for additional supplies and believe that we can give better particulars in the new week. And then from there, we will pivot towards a major exercise, assuming the vaccine comes in, to try and inoculate the entire cohort of qualified individuals, all age groups over the 18 years. And there is a fairly elaborate plan to get that going. So we hope that will happen. In the meantime, protect yourselves, protect your family, protect your community, and let us work together to push back this COVID health threat. Thank you very much.